patient's consent, or if they're not conscious, it's under your family member. It's a fairly invasive procedure. And what this does is it can take contents out of the stomach. And as Delia said earlier, it used to be used to, feeding. So you hear NG tube, and but people don't typically do that anymore. So to assess, the first thing we're going to do is basically you'll take your tape and you check for the distension, and you'll know how big their stomach is, and it's used for dysphagia, for the trouble swallowing, and to get these contents out of their stomach. So we're going to start off, and we're going to show how to get the tube in, and while she's getting that set up, I'm going to pretend I'm auscultating the abdomen.
Never pretend.
So you want to come over here. Typically, they would be a little more laid down, but we're trying to save some time here. So if you're going to listen to the quadrants, like we're all used to doing, and we're just going to hear how active the valves are. Because if their valves are active and they're kind of getting rid of the stuff, then the swelling may go down by itself. But if not, we need to get that stuff out so that we can see accurately what's going on within their system. Ready?
Sure. Okay, so, you're going to do the same things that you normally do. Like I said, doctor's orders. You're going to do 2 patient identifiers, get their permission, hand wash, and then you're going to get your PEG tube, not PEG tube, your nasogastric tube, and you're going to want a little bit of lubrication with it. You're going to need all this stuff here. And you want to make sure that you have something to attach it with. Depending on what your facility uses, this thing looks really cool.
Can you elaborate on what all this stuff here is?
This is the butterfly, so that whenever we do the facility, and like she said, we're going to get to it. So this goes across and this kind of holds it.
I just want to know what supplies we needed gathered.
She'll explain it. Well, and you're going, it depends on what kind of tube you want inserted, what the doctor wants you to do. So you're going to go to your supply room and you're going to look for your nasogastric tube.
And it's its own type of tube.
Exactly. It has the little holes, and I'll let y'all guys pass this around and look at it, I guess. But it's got the little holes at the end.
So the supplies you're going to need is the nasogastric tube, the size that they want. You're going to get a big old syringe. That's a technical term. Butterfly. And you're going to make sure that you put 2 pillows behind the shoulders and the back and keep them in a high balance.
And your lubrication stuff. You're also going to want to make sure that you have a towel to go over your patient. And this is what they gave us to demonstrate with. I would get a bigger bucket, just in case. Because if you hit that gag reflex and they ralph, that's not going to catch it. But you're going to put on your gloves, of course. And you've already done your abdominal assessment, so you're going to assess the skin here and make sure that they don't already have some skin breakdown. And you want to look inside the nostrils and make sure that they don't have any occlusions. You may want to have them blow their nose if you see that it's kind of yucky up in there. Anyhow, and then you're going to open up your tube, from the brand new package. And you're going to measure. You're going to start at the nostril here. You're going to go back to the back of the jaw where the ear is. And then you're going to come down to the end of the sternum. And you want to mark that like with a little piece of tape so you can keep track of it. Because that's about how far you're going to want this thing to go in.
Down to the xiphoid process. To the end of the sternum, is that what you said?
To the bottom of the sternum.
At the bottom of the sternum. And so, whenever you're ready to insert this, you've taken it out of the package. You're going to kind of have it, anyhow. You're going to open your little lubrication stuff, and you're going to lubricate the first 3 to 4 inches here. And on this little tube, there's a 10 here, so that's where I would say lubricate is about 3 or 4 inches. And then you're gonna have your patient kind of lean their head back just a little bit here. And decide which nostril you're gonna go into. If you're gonna go on this side, stay on this side. If you've decided you need to use the other side for whatever reason, go around to the other side. So with the head tilted back just a little bit, you're going to tell your patient, okay, well, I'm going to start inserting now. Go ahead and take a deep breath. And then, as it's getting down there and you're getting close to the back of the throat, we're going to have them lift their head up, right?
Tilt it forward, yeah.
Yeah, tilt the head forward some, and then you're going to tell them, okay, now just start swallowing for me. Okay? You swallow, swallow. And if they're having trouble swallowing, you may give them just a little sip of water. Tell them keep on swallowing. If you meet any resistance, stop. Depending on how far in you are, pull back a little bit. Twist it toward the middle of the nose. And see if you can keep on going. If you can't, then you're going to have to just completely remove it and get a new kit and start all over on the other side. So you're going to continue inserting, and if they start coughing or anything, again, you need to pause. And this dude doesn't go all the way up to here, but it should go all the way up to here once you get where you need to. Once you get to your tape, or just about to your tape, let them relax, and then you're going to hold that where it's not coming out. And we're going to attach. And you want to put your stethoscope on and show what we're talking about here? And you're going to attach, and you're going to need to have this already have some air in it. And you're going to listen just, below where you want this to be. And you're going to listen for a little poof of air. Okay? And then at that point, you push the air in, and you should start seeing some fluid coming back up. If you don't hear the air, you may have gotten it in too far, or you may even have it, if you get it into the lung, it's going to hit that carina, they're going to start coughing. That's part of that cough reflex. When I was saying back up, anyhow. So if you hear the puff of air and you see it coming up the tube, then you know it's in the right place. So we're going to attach the tape stuff here, and we're going to let it go.
They'll either be coughing or short of breath.
If it's in
That's in
the,
the wrong place. Pull back.
All right, now, since we've got this coming up, you want to pull a little bit of the gastric fluid out, and you're going to just kind of set that to the side for a minute, finish up what we're doing. You're going to have this on low-level suction. It should say in the doctor's orders what the suction needs to be on. And, of course, as it's draining, you're going to mark over here for your I's and O's, just like everything else. And so you've got your gastric juices in here. You're going to get one of these little testing strips, and I'll pass this around here in a minute. This will test for just about everything, but specifically you're looking for pH for the stomach. And I think the other said 1 to 4 earlier, didn't you? So just get it over the trash can so you're not making a mess, and just run it over all of them, see what comes up. And you're going to look at this and specifically look for the pH and report the pH. Anyhow. And then, what else am I demonstrating?
Irrigation.
Irrigation, okay. Okay. I think that's the last thing I'm demonstrating is irrigation. Sometimes as this is draining, it gets clogged up and it's not draining anymore. So, that is what this is for. You're going to put some water in it. Just regular water. And if you see this not draining anymore, make sure you're not letting it leak all over you. Of course,
You want to turn the suction off.
It's not making any noise. Of course, turn off the suction. before you disconnect it, or you're gonna, anyway. You're gonna get about 30 mils of water, and you're just going to, take out the other little piece of suction out of the other thing. You're gonna go right back into the tube here, and you're just gonna slowly, and if it's clogged up, you may be meeting some resistance, but just try slowly to push that through. And if it's pushing through, then you know it's unclogging. And once you get to the end here, and all your water's gone in, then you need to pull back out 30 mils. Because, I mean, you've got this tube in draining, so you're not trying to push more stuff in. So whatever you put in, take out, and then hook it back up. And you should see it start flowing again. Okay. Yeah. Turn it back on, you should see it start flowing again. Okay, the blessing on demonstrated. Okay, and then of course clean up your mess and take all your junk with you. Your client doesn't want any of this stuff. Close off, hand wash, bed down, all that fun stuff.
If the doctor, when you get done with all of that, you're gonna just discontinue the tube. Of course, you wanna make sure that you have a towel, and a bucket of some sort. What do you have?
DC in the tube, taking it out.
Taking it out. Of course, you're gonna have your towel here, and a bucket or some kind of something, you know, to catch the fluids. You can use, yeah, you wanna do a medical hand wash, put your gloves on. Delia was saying that when she does this, most of the time, she likes to have a paper towel in her hand. You can have a rag in your hand, whatever, you know, hospitals are trying to go green, so, whatever. Anyway, so all you're gonna do is, you know, get your tape adhesive remover. You know, you're gonna make sure that you remove your nostril piece here. Okay, and then, you know, you have a paper towel here or a rag or whatever, you know, and you're just gonna calm the patient down, you know, and just keep them calm and have them either take a deep breath, or they can blow out their nose, whatever is easier for them. And you're just gonna, you know, just gradually pull it out, you know, and you don't wanna get this stuff everywhere, so, you know, you're gonna grab it in a paper towel and contain all of that. And, of course, you're gonna have your suction off and make sure that that goes into your biohazard bag, you know, and then you're gonna clean your patient up, of course, and they're gonna feel a lot better when that's out. So, you know, at that point, you wanna make note of the skin integrity, any, thing that's going on with the nose. You wanna check their oral, way for irritation in the oropharynx area. Because that's something that you want to document in your documentation. You want to document, you know, the abdomen girth before and after you do this procedure. You also want to document your I&Os, how well the patient tolerated the procedure, you know, of course, the equipment that you used, anything like that. So that's about everything, yeah. Of course, you're gonna, you know, put the patient back down into a comfortable position.
Would you throw that tube away in a biohazard bag or just the regular trash bag?
Biohazard bag, yeah, it's internal juices.
That's what I thought, just making sure.
Be dug out of the trash.
Do you pull it out that fast?
Yeah,
At a
continuous.
steady,
Yeah,
yeah, at a steady.
Yeah, don't stop.
And go and stop, but just at a
Once you
steady,
stop and you
steady.
get that to the oropharynx, they might start choking and coughing and vomiting, you know what I'm saying? So,
You
yeah,
just wanna
wanna
get it
out of there.
So the next one, guys, a peg tube, do a bolus. And typically what it's gonna look like, we were told to use a 4x4. There's also these little doodads. These like a 4x4 that's cut on a diagonal. They're going to spin around just like this. And they can be picture framed in. So the first thing you're gonna do is you're gonna assess it. You're gonna look for any drainage on the 4x4. You're gonna take it off and look for any redness. The skin should look normal around there. There shouldn't be any red. There shouldn't be any off-colored at all. There shouldn't be any drainage. If there is, you need to note it. and notify your TPCN. Okay, so after you've looked at it and everything's fine, you want to put a new one on, you'll either take a 4x4 and cut it at an angle to put it on and picture frame it, or you can just get one of these if they have it. So it's pretty simple. So you'll just put it on like I just did, picture frame, remember time, date, and initial, because if you didn't, they don't know, because it needs to be changed every day. Okay.
So, now I'm gonna be demonstrating the peg feeding. So you gotta make sure that there is consent, because this is surgery, so you wanna make sure that the patient has consented to have this inserted. The day-
One moment, do we clean the site? Did you say to clean it?
Oh, that's right, I'm sorry.
He was gonna demonstrate cleaning after.
Later? Okay,
but
okay, well
that's
then,
okay.
I
Go
can do
ahead.
it now. When you get a 4x4, what you do, it's really important, is that when you're gonna come down each side, you don't wanna drag anything. So basically, you're gonna kind of roll it on this side, get another one, or a piece that you haven't used, and then roll down the other side, so that you don't spread any bacteria from one side of the wound to the other. And that was the big part of that.
What are you cleaning it with?
You can use, usually per doctor's orders, but it's gonna be your sodium solution in the 4x4 like we have. Is that good?
Sometimes it
I
might say
usually
soap
just
and
dab,
water.
I usually dab one quarter and then get another one, and dab the other quarter, you know. But, yeah, that's right.
Okay, so, the patient has this inserted, now it's time to feed them through their peg. Every time you're going to be doing this procedure, you want to make sure that you oscillate the abdomen, you want to check for distension, any pain that the patient might be assessing pain. You also want to look at the wound and see that the wound is also, is not any redness or anything like that. If there is, you definitely want to report that to your TPCN. And so to do a bolus, which is just, you look at the doctor's orders, and they're going to specifically say feed them 200 mils. So before you get started, this has a cap on it, so you remove the cap. You want to pinch it here because sometimes it'll burp. So I'm going to pull that out. You're going to put your syringe here. You first want to flush it, so you'll have your cup. You'll have 30 mils of water, and you'll flush the
Do you mind
line
turning-
first.
Yeah, we can't.
Do you mind turning it back here?
Okay?
You just flush it with regular water?
Yeah, you can flush it with water.
Do you want it to be warm or
No, you don't want it to be cold, because it can cause
just
cramping.
regular?
Just regular room temperature, So you flush the line first, then you take your bolus and you just pour slowly. You want to observe your patient, see if they're, how gagging or choking or, complaining that they're having any pain or discomfort. Then you just discontinue, wait, give the patient a chance to adjust. Then you continue to feed. And then when you're done feeding, you then flush the line again with another 30 mils. And you flush it, okay? You want to pinch it, you remove your syringe, and you cap it. Okay. Then what you want to assess is how much you fed the patient, so you do that in your eyes and nose. You want to assess how the patient tolerated. You also want to indicate not just the 200 mils or the 100 mils that the doctor prescribed, but also that you flushed with 60 mils, right? 30 and 30. So you want to make sure that you document that with your eyes and nose. Excuse me?
Gloves on.
Absolutely, always gloves on. Medical hand wash, gloves on. The 2 patient identifiers, you're going to do all of that basic stuff.
What position are they in when you're feeding them?
Never
They're-
below 30 degrees.
Yeah, they're sitting, I would keep them in anything up in a semi to high Fowlers.
At the NG tube, they have to be in a high Fowlers. With this, you just don't want any reflux going on, so,
They can possibly aspirate.
yeah.
So, that is, again, when you're documenting, you want to make sure that you document how the patient tolerated, eyes and nose, and you just follow the doctor's orders, whether it's Q2 hours, Q4 hours, Q6 hours, and you just follow what the doctor's orders are. And that's pretty much it. You do. Huh? And then if you want to check, sometimes a doctor may ask for residual. The reason for that is to making sure that the patient is actually absorbing the nutrients. So to check for residual, basically,
Yvette, real quick, was that other procedure sterile or is it just?
no, it's clean
Clean
gloves.
gloves.
It's not sterile. It's clean.
And before you did that, did you check placement, or we don't have to check placement?
It's placed in surgery, so
Yes.
they're checking it, they check it before they even have that cut.
Yeah.
you're just osculating, is basically what you're doing. You're osculating, assessing the wound site, and you want to just see if there's any continuous distension, if they're in excessive pain. So you'll be assessing all of that. To check for residual, you do the same thing. You're going to actually have a regular syringe with a hooky in it. So you'll have your syringe, you're going to pinch, you're going to open the valve, you'll put this in, and then you're going to draw. Now, the doctor's orders may say if you draw out 100 mils or more, then you discontinue feeding, and then you would do that. You would discontinue. So you would just basically pull out and continue to pull. So let's say your syringe gets full, you look at it, okay, I got 60, discard. You can do it in the sink or in the toilet. You discard, you come back, you pull again, and you keep doing that. If it stops at 90 and the doctor's order says 100, you can continue feeding giving the bolus. Some doctors may not ask to check residual, so you just basically, you don't do residual on your own. You have to have doctor's orders to do that.
What did you say?
So residual,
You want to make sure to absorb if they're absorbing any nutrients, because if the bolus is just staying in their stomach and they're not absorbing anything, and you just continue to feed and feed and feed, then they're going to get distended. It's going to defeat the whole. They're not getting any nutrients.
So after
You come
feeding,
back and check after- You come back and check that after how long?
yeah, that's what I was about to ask.
Okay, so you just discontinue one feeding, and you go, right, you just go to the next feeding, you
And
check
you
again.
don't necessarily discontinue the feeding, you hold the feeding.
But after you
When do you come back and do that
That,
residual?
Yeah.
your order will tell you hold for 8 hours.
8
Your
hours,
order
and
will-
then you come-
Your order will specify
All that
at
stuff.
all, whatever holdings, how much residual.
When to do residual.
That's what they're asking, like after you give the bolus, the doctor's orders will tell you when to come back and check for residual.
Okay.
And you
a
won't
lot of
give,
the
you
stuff
won't
that
give,
we're demonstrating, it's either gonna say it in your orders, or it's gonna have it in your policies and procedures. Every facility is different, so you really need to check your policies and procedures. Some hospitals or some facilities might want you to automatically check residual every single time, or check for gastric content every single time. Even after this, you might be ordering a chest x-ray every single time. It's in your policies and procedures, so whatever, you know what I'm saying?
But it's a doctor's orders. A policy and procedure can't tell you to do that. It has to be ordered by
Yeah.
a physician.
I'm just
Okay.
saying, it's either gonna be in your doctor's orders or it's gonna be in your policies and procedures.
go with your doctor's orders,
But if it's
but
in your
do look
policy
it
and
up in
procedure,
your
you can't
policy.
just do it, you have to have a lot.
Right.
Go ahead.
Can't do it without a doctor's
We're just
order.
trying to get the basics here and make sure we understand is all we're asking.
Not a problem. Okay, so now you've checked your residual. If it's under the 100 mils that the doctor said, you just go ahead and feed your patient. You'll flush the line, you'll feed and flush the line again, and you'll document that in your eyes and nose. And that's how a bolus is done. It's really, this is actually the easiest one. And always you want to make sure that you can interact with your patient, make them comfortable, talk to them, because I can only imagine how awkward it must feel to be being fed through there as opposed to eating within your mouth. So always keeping in mind that, you want your patient to be comfortable and happy.
Okay, I'm gonna demonstrate. I'm gonna demonstrate, the continuous feeding. So this is like, they have to pay 2 weeks placement surgery. Everything's the same except for the doctor's order just to be continuously be feeding them. And you're gonna be using a kangaroo pump. You're gonna be using a kangaroo pump. It's kind of like your IV pumps. You can set it however the physician orders it to be set. And, you have like different options here. So like if you're changing your patient, you can put it on hold so that so you can lay your patient down and change them or reposition or anything that they need to be done. Some hospitals use like a port to attach your peg tube for the feeding, and you'll always get your feeding from the pharmacy. They'll send it down. The dietary, sorry, send it down. And you'll just connect that, and I'll pass this one around, because it's got, a valve here, and you wanna make sure that your valve is on. There's arrows that show you which ports are being opened, and so you'll just connect that with here.
Can you move that in front of me?
This is called a Lopez valve.
And, you'll just connect it here, and then you'll have your patient, make sure your patient's always at a 30-degree to 45-degree angle, because this is a continuous, you're always gonna have to be at that position. And then you'll make sure that your valves are open, and, you'll turn your pump on, and it'll just go through. And with this, because you have this, you can also give meds through your port, through this three-way port. And you'll do it the same way you would with kind of like the peg tube with the bolus. You'll turn your feedings off, and you'll just do that by turning your valve. And then you can, there's a port on top that you would connect like a syringe. And you'll flush first with your 30 mLs of water, and then you'll have your crushed meds mixed with your liquid, and you'll pour that down also. And then to flush your line again, you'll pour another 30 mLs down, and let it all go through, and then you'll close that and reopen your ports to continue feeding. And, I just thought of something.
Is it okay to tape the connections? If you have to tape it to get it together, it's not painted.
Oh, no.
So, you'll see it taped, but it should not be taped. That means it's not painted, so everything's coming back out.
Do you always flush with exactly 30?
That's what I've been wondering. Is that standard, 30 mils?
No, your order will
Okay.
specify.
That's what I've been wondering this whole time.
If you see one taped up, should you just go get a new one and redo it?
You can get the little port.
Mm-hmm.
You can get it it'll come with your irrigation tray.
Mm-hmm.
You'll get the canister, the syringe, and and you can get that port. You can remove the port and replace it, but some of them are connected to the tubing.
Okay.
So all you have to do is just report it to your TPC. Okay?
I saw this in
Okay.
right now.
Each one?
Medications?
Yeah, like we have multiple ones, so.
One bolus.
You use, one bowl. If they're crushed or liquids, you can put them all in that same cup
Okay.
that you're pouring into your syringe.
But you always want to flush with at least 10 mils after your meds, the chaser is what they call it. But,
Or just whatever
yeah,
the
you
doctor's
definitely
orders.
want to document your I's and O's, any residual. You also want to document, if you, when you clean this, what you used to clean it with, any skin irritation, anything like that. How well the patient tolerated, your basic documentation stuff.
And don't just assume just because your orders say this much per hour, that that's how much you're giving. Because somebody, like, even if it's not you that comes in to reposition your patient, somebody else could reposition your patient and turn your feeding on hold. And so they didn't get the full amount that they were ordered for that hour. So you just want to make sure that, and it's just like the IV pump, it'll say how much was infused for that time period.
This is called a kangaroo pump. I don't know if she said that.
She did.
Also, I was a little confused when I first saw the NG tube, and it was demonstrated to me that this tube right here, you never connect anything to this tube. It is strictly for airflow. You're always connecting right here. So I just wanted to say that. Never connect anything to this tube.
Good enough, because I was curious.
And before you insert, curve your tip a little bit.
Yeah, you can just make it soft. You can curl it around your finger or just to kind of curve it a little bit to make it easier.
Just make sure it's not coming out the mouth.
Yeah.
Sometimes it'll curl back in their oropharynx area, you know.
You keep on going.
You not wanna have your thing out with you when you're doing it.
Let me pull that out a little bit.
What is the reason why they're having
Straighten
these
it up.
tumors? What's their problem?
Maybe like aspiration, they can't.
Swallow.
They could be distended, they could be suffering from dysphagia, they're not able to swallow properly, so they can't take any nutrients by mouth. So they're needing that to be inserted.
They could have a crush injury, you know, something that's messed up their throat, they can't eat or whatever, you know. I mean, there's many of these. This right here is basically for distension, you know, that they're not absorbing those, that fluid that's in there, so we wanna get it off, because it's freaking hurting.